Assalamu alaikum, the clinical day. We have Mr. John, 40 years old, came with complaint of back pain. We are starting in seconds. Okay, ready?
Okay.
Here you go.
Hello.
Hello.
My name is Dr. Mahmoud, one of the here in the clinic. Am I talking to Mr. John?
Yeah.
And can I confirm your age is 14 years?
My age? 40
Yes,
years old.
so, I'm here today to discuss about your health condition, and I might ask you some question, and I will examine you, and at the end I will address all your concern and answer all your questions. Is that okay with you?
Yes, okay.
Okay, I can see that Mr. John coming today complaining of back pain. Is that right?
Yes.
Can you tell me more about that?
What you say?
Can you tell me more about that?
Yes, since 6 months, developed very severe back pain, difficult to do my activity like before.
Yes, I'm really sorry about that. It's quite distressing for you, but I want to assure you that we'll get to the bottom of this. You told me that you have this back pain 6 months. Did it start suddenly or gradually?
It started gradually.
Gradually. And
It became very serious.
Hmm?
It started gradually. It started minimal and now became very serious.
Okay. And when have you noticed anything that make this pain started as you had a trauma or anything?
No,
Okay. And you didn't fall on your back?
no,
You didn't lift any heavy object or do any vigorous exercise before having such pain?
I'm not sure.
Okay. So you told me that it started gradually and now it's become more severe. Can you score this pain for me? 0 is no pain and 10 is the severest pain that you have ever had.
8.
8. Do you want me to give you a painkiller now?
No, thank you. I'm sick already.
Okay. So this pain, have you noticed that this pain is specific to a certain time of the day? More in the morning, more at night?
All of the day, but mainly at night.
Maybe.
Became severe at night, but all the day.
And have you noticed that this pain has become more worse with movement?
I'm not sure.
Yeah, not sure. Okay. And you told me it's more at the night. And also with this pain, have you noticed any stiffness in your back?
Yes.
And this stiffness is improving with movement or it is worsening?
Yes, improve his movement, yes.
And this stiffness also in the early morning or all over the day present all the time?
Early morning.
And improve with
After few minutes, improve, yes.
after movement improve.
Yeah.
Okay. And can you tell me the character of this pain? Is it dull, achy, stabby?
I'm not sure, but very severe pain.
Very severe.
I'm
Okay.
not sure.
And have you noticed this pain is radiating to any part in your body?
No, in my back.
Okay. Have you noticed also any numbness or pin and needle sensation in your leg?
No.
Any when you go to the loo and try to wipe yourself, have you noticed that you're not feeling your back passage?
I don't get your question.
When you go to the toilet and try to wipe yourself, you feel that you lose the sensation on your back passage?
No.
Okay, any change in control of your bowel habits or urine?
No, it's okay.
Okay. So, coming back to this pain, have you noticed anything make it better?
No, only after nothing but painkiller, I think. After take painkiller, minimal improve, but not totally.
Okay. And just some question, yes or no. Do you have any fever?
No,
Any change in your bowel habits?
no.
Any pain in other part of your bone or your body apart from your back pain?
Yes, in my in my foot.
Both foot?
Yes,
And when exactly in your foot? Where?
I think all over is my foot. Don't don't remind the specific area, but
And,
feel pain in my foot, but mainly in the posterior of my foot.
okay, okay. And have you noticed any redness or swelling in your foot?
No,
And this pain started same as the time that you have this back pain?
no, after back pain.
After, okay. Any other joint pain in your body or swelling?
No, no,
Have you noticed anything, any pin and needle sensation in your leg or in your arms?
no, no.
Okay, okay. Had and also any any redness of your eyes?
Yes, but now no. Before 2 months, I think.
Yes.
Noticed, no, but now clear, nothing.
So is having redness in your eyes, in both eyes.
Yeah, before. Now, no.
And this redness was also painful, associated with pain, or only redness?
Painful.
Pain. Okay. And it went on its own, or you took any medication for it?
Yes, went to ophthalmology.
Ophthalmology, and what they give you as a medication?
Um, give me medication, yes.
And he told you what is the cause of this?
I don't know. He said name, but I don't remember.
Okay. And have you noticed also any change in your vision?
Uh, no good, no.
Okay. Any difficulty in swallowing?
No,
Any rash on your body?
no.
Um, any heart racing?
No.
Any shortness of breath?
Yes.
Can you, when this shortness of breath started?
What you mean?
You told me you have
When
shortness
start?
of breath. When it started, this short
Yes. Before 2 months, I think. 2 months.
2 months. And what do you mean this shortness of breath is at rest or on exertion?
Both rest and exertion.
And it's increasing or is the same?
No, increasing from starting now, increasing progressive.
Okay. Any cough?
Yes, mild cough.
And this cough is associated with phlegm?
No,
Okay. Have you noticed any change in your weight?
no,
Any lumps or bumps on your body?
no.
Okay, Mr. John, you told me that this condition affecting your life. And it's not helping you to perform your daily activity. So what you do for living?
Uh, I'm driver actually.
You are a driver. And
This is my job because not learning.
and how is this affecting your driving?
Yes, more.
Okay, so I highly advise you to hold your driving till we'll get the bottom of this, because you have this back pain, and also you told me that your eyes also was red, so it can affect your vision and can expose you and the surrounding to be at risk. What do you think if you can hold driving till we get the bottom of this?
I can't. This my job and this my financial support. from this driving.
I really appreciate that,
No,
but
no other source.
I really appreciate that, but we can help you with that, and we can include our social service, so you can be prioritized to some financial support till we get the bottom of this.
Okay.
Okay, and can I ask you some question regarding your lifestyle?
Yes, no problem.
Do you smoke?
Yes,
How many cigarettes per day for how long?
5 cigarettes for 5 years.
Yeah, I highly advise you to stop smoking. We will help you by referring you to the smoking cessation clinics because this can affect your health. Okay.
I was thinking.
Okay.
No.
Okay. And what about alcohol? Do you drink?
No, socially only.
That's great. Okay. And do you have any medical conditions that you should be aware of?
Uh, was high blood pressure.
High blood pressure and what? And
Only high blood pressure,
yeah,
nothing more.
what medication you are taking for your high blood pressure?
Taking lisinopril.
And your blood pressure is controlled?
Yes, control. Good.
Okay. Are you taking any other medication apart from lisinopril?
No, apart from this painkiller, no, nothing.
Any over-the-counter medication?
Only painkiller.
Painkiller. Okay. Have you noticed any rash on your body?
Asked me before, said no.
No. Okay. Okay. So I would like to examine you now. Is that okay with you? And I might ask you some question.
Yes, it's okay.
Okay. First, I would like to check the vitals.
Yes, good.
Normal.
Yes, blood pressure 130 over 80, and pulse rate 75.
Hmm.
What more? Respiratory rate 22.
22.
And yeah, and temperature 37.
Okay. And can I check the blood pressure standing and sitting?
No, normal.
Okay. So I would like first to examine the back for any tenderness, any swelling, redness.
No, only tenderness, nothing more.
Only tenderness. Okay. And I would like to proceed to check also for, he said that he has also pain in his lower limb. So I would like to check the foot for any, the joint of the foot. Any
Yes,
tenderness.
the smile. What area you want to examine
I
in
want to
my side?
examine the tendon, tendon Achilles.
Yes, there is tenderness.
Okay. And any swelling or redness for any joint of the foot. I would like to palpate.
No,
Okay.
no.
Okay. I would like to check the sensation of both foots for modality.
Yes, normal.
Normal. And the reflexes.
2 minutes left.
Also normal.
Can I check the chest
For what?
for crepitation or wheezes?
Yes, yes, there is apical crepitation.
Apical crepitation.
No
And
wheeze.
okay, any change with cough?
No,
Okay, and then I will examine the heart for any murmur.
no murmur. No,
No. And okay, and then I'll examine the abdomen for organomegaly.
no organomegaly.
Okay, and I would like also to examine the eye, the visual acuity,
Normal.
visual field.
Also normal.
Okay, so Mr. John, what is your main concern?
What is wrong with me?
Uh,
I'm really suffering.
I really appreciate your concern. I can see how you have all this pain for 6 months. There is, I have many things that run in my brain, but one of them is that you might have a condition called ankylosing spondylitis. Have you heard about this condition before?
No,
So this condition is a condition that cause inflammation in your back and in your leg and also in your eyes. And it also can cause the shortness of breath that you have. So I would like to do for you some investigation, including blood tests and some imaging, and I'll include a multiple doctor to confirm the diagnosis, and then I will come back to you with the plan of management.
It is a cancer or no other cancer?
Most probably it's not a cancer, but with the scanning and test, we need also to exclude cancer. But most probably you don't have cancer.
Okay.
Okay, time is up. Start the examiner question, please, Dr. Samah.
No,
It give you chance to examine other part of the body. Which part you examine it?
for this patient, I will examine the upper limb, the joints. I'm not quite sure on this.
Will هنا answer it or after finish examiner question?
No, finish the examiner question. But
Okay.
yeah,
Can present your case?
Yes, I examined this gentleman who's presented with back pain, which is a chronic back pain over 6 months that is affecting his daily activity. This back pain is associated with morning stiffness, and he also it associated with inflammation. He has also positive finding, including apical crackles on his lung. He has inflammation in the tendon of his leg, the tendon Achilles, and he has an episode of scleritis. Putting this all together, this patient, I have many differential. One of them is ankylosing spondylitis on the top. So I would like to run for this patient further investigation, including the routine, apart from the routine test, which is full blood count, liver function, kidney function, CRP, and serum electrolyte. I would like to do for him
أمي أنت لا تغسل يدك لا تتوضي
a chest X-ray and
أنا يومي خدتي أنا يومي أنا من دير خدتي وخدتها
chest X-ray echo, and chest X-ray echo. Also, I would like to do an X-ray on the back, and also an X-ray in his lower limb. And I want to include multidisciplinary team, including the rheumatology team and the occupational therapist, the respiratory team, and physiotherapist. This is my case.
This presentation. What investigation should do for this patient?
I said-
Before investigation, what is the differential diagnosis should be excluded?
Yes, for differential diagnosis, the top is ankylosing spondylitis. It could do also, it could be osteoarthritis, and osteoporosis. We need also to exclude discitis, inflammation, and cancer, psoriasis.
What else?
Osteoarthritis, spondylitis, and other cause. Yes, the other differential also we need to exclude other cause of apical crepitation as histocyte in any infection, histocytosis, cool pneumonitis, radiation pneumonitis, and tuberculosis. This is my definition.
تمام. What investigation should do it?
Yes, for this investigation, I would like to do general investigation, including, as I said, full blood count, renal function, liver function, inflammatory marker, and specific test, including first, I would like to do an X-ray of spine, X-ray of lower limb, chest X-ray, and echo, high resolution CT scan, and HLA-B27, and other immunological marker, including ANA, ANCA, anti-rheumatic factor, anti-systemic lupus.
For what?
Other autoimmune marker.
مش related. خلاص finish now? Finishing
Still 15 seconds, yes.
investigations. What is the treatment type? What is the treatment?
Yes, for this, the treatment should include multidisciplinary team, including the rheumatology, the physiotherapist, social service, and the respiratory team. The pharmacological treatment for ankylosing it could be a strengthening exercise. It will start with painkiller. We can start also with DMAR, disease modifying agent, and this is the treatment.
What other?
This is the pharmacological treatment. We can also include the physiotherapist, as I said, to do strength exercise, to strengthen the muscle, and the occupational therapist that helps the patient with house condition and to keep the home safe for him. And the
خلاص حسبك. What is the cause of shortness of breath for this man?
Yes, it could interstitial lung fibrosis. This is the first cause. And if she starts the treatment, it could be one cause. The cause could be the treatment, and also it could be aortic regurg, because ankylosing can cause also aortic regurg.
What else?
And it could be also the bone itself, bone deformity, scoliosis.
The restriction of chest expansion.
Yes.
تمام. What else?
It could be anemia of chronic illness.
Anemia. Yes, good. What is the renal complication for
Yes,
this patient?
amyloidosis.
Yeah, what else?
Renal complication.
This
Amyloidosis.
patient take over-counter painkiller.
Yes, it could be have
What?
interstitial nephritis.
Non-steroidal use. أيوة. ممكن نعمل له كل السايد افكت الرينال. نيفرايتس ولا intrinsic allergic أي هنا. No problem. خلاص. What is the diagnostic criteria
For
for
ankylosing.
the patient is ankylosing? Yes.
Diagnostic criteria.
Yeah. Modified
Yes.
New York criteria. Like اسمها كده modified New York criteria. نمشي one by one.
Okay.
دكتور قاسم.
Yes, go ahead, Dr. Sabah. Go ahead.
There is time
Yeah,
to
7 minutes.
follow all steps. Okay.
Yeah, of course. Yeah,
Okay.
go ahead.
Okay. You ask about associated with this stiffness or not? For how long? Which part affected of your back? I think you ask about it. How
Yes.
long ago did first notice symptoms? Ask about it also. Any inflammation or redness in the eye? Ask it. Skin rash? Ask it. Why ask about skin rash, Dr. Sarah?
For ankylosing skin rash.
Why asking in ankylosing case? For what?
For associated enteropathic as inflammatory bowel disease, dermatitis herpetiform, and no.
What other most important things
In ankylosing?
Yeah. Skin rash to exclude most likely differential psoriatic arthritis
Yes, psoriasis, yes.
because
Yes.
strong overlap between. So
Yes.
skin rash, shortness of breath or dry cough, already asked about it. chest pain, palpitation اللي هي awareness of heartbeat, ankle swelling, shortness of breath, ankle swelling, I think not asked about it. Shortness of breath or lying flat or at night. Any history of tendonitis, already asked about it. Um, infection prior to this pain, any history of infection. Example, diarrheal illnesses for inflammatory bowel disease, also strong differential. Uh, discharge from penis or vagina or urine cannot see for reactive arthritis.
Yes.
Strong differential. برضو ask about traveling unprotected sex like this. Anyone in family have the same condition, have
Yes.
the same joint problem. Anyone mentioned heart murmur already in examination, but should ask in history. Anyone's asked search for you there is any abnormal heart murmur like this. Lung fibrosis, kidney problem. Kidney problem, I think not asked it, صح?
No, I didn't.
Any أيوة change in urine, frosty urine. This is important because patient on painkiller should ask me what is the type of painkiller which she take.
Yes.
Ibuprofen, diclofenac, because if take paracetamol not affect the kidney. Should ask about which name of paracetamol take.
Yes.
About heartburn also. Any recreational drug, I think ask about it. What you do for work, ask about my job and said driving and stop my driving. Any problem affecting your daily activity? Yes. Yani how this disease affect your daily activity? Yes. Any particular concern? Ask you to concern about it is cancerous or what wrong with me. I think answer both question. System should be examined. You will not examine. Most important, kyphosis, kyphosis in the back, and loss of lumbar lordosis. This important is the posture.
Yes.
Not remember it. Also, ask about most important system should be examined. Should examine the skeletal for ankylosing itself by
Yes.
movement. Ask about movement, lateral movement, forward movement.
Trouble.
Yes, modified sugar test also, or برضو targus wall movement, targus wall distance or occipital wall distance. Most important things for ankylosing spondylitis.
Yes, you are right.
Also, chest expansion important because there is restriction due to fibrosis itself, due to ankylosing itself. I mean, respiratory ask about apical episis by fine crepitation already done. Cardiovascular ask about murmur already done. Displace apex can do also collapsing pulse or not to exclude the wide pulse pressure for
Yeah.
aortic regression.
Aortic regression, yes. Also.
Yes, tendonitis, apical Achilles tendonitis already asked about it. Differential should do HALA B24. He associated with other seronegative. Should exclude all
20
other
27 دكتور سما.
Okay. 27, yes. HALA B27, yes. بتكلم out of mind. Associated مع الثروباثي like psoriatic arthropathy. Due to this, we'll ask about skin rash, reactive arthritis. Should ask about any sexual any diarrheal illness also, and also ask about cannot see
Yes, yes.
because strong association, eye infection and other joint
Yes.
arthritis. Inflammatory bowel disease should ask about diarrheal illnesses before. Also osteoarthritis, but cause mechanical. Against rheumatoid arthritis is inflammatory.
Yes, yes.
Rheumatoid arthritis also, but not cause back pain mainly. affect a small joint of body, of hand.
Yes.
Malignancy also differential. You remember you remember it. Diffuse idiopathic skeletal hyperosteosis. الكابتونيوريا بيكون associated with pigmentation في البنة. This rare باعتبارها حاجة congenital كده. Investigation bedside investigation, blood pressure, white pulse pressure,
And also
echocardiogram, AV conduction block, yes,
pulmonary
and
function.
also aortic rigor also. Urine dipstick for proteinuria, oxygen saturation for hypoxia.
And also
Blood,
yes,
what?
pulmonary function test for obstructive or restrictive.
Yes, I will remember it later. But now about echocardiogram, blood pressure, and pulmonary function test. Special is spirometry also for restrictive lung disease, and aortic echocardiogram for aortic root dilatation and aortic regurgitation. Blood general أو basic investigation, full blood count for anemia, is ROC reactive protein, inflammatory, urea electrolyte because the secondary للاميلودوزس. وقلنا النان chronic non-steroidal use. الهالة B27 is positive but not diagnostic. بنعملها screening test. الإيميجينج بلينفيل in early stage X-ray is good diagnostic measure, but in early not early appear clear or normal. Should do MRI. MRI is fine. Show early evidence of inflammation. To show syndesmopide, البومبوسباين, joint sclerosis. Yes, radiograph for apical fibrosis or high resolution CT scan also for apical fibrosis. Treatment non-pharmacological, pharmacological, and surgical. And non-pharmacological education, advice, education and counseling about condition. Refer him for social, rheumatology, rheumatologist, specialist nurse, physiotherapy. Encourage exercise like swimming, most important. Swimming and hydrotherapy, most important than physiotherapy. Monitor associated condition, cardiovascular disease, osteoporosis, and fracture. Medical analgesic use, non-steroidal if tolerated, if no side effect or renal affection. This is the initial start by non-steroidal. Try to non-steroidal before start other medication, and also paracetamol and amitriptyline. Steroid, oral or IM or IV. DMARD not effective, used but not effective. Should use biologic agents like الأديلوماب والإنترنسبت والجوليموماب. monoclonal يعني. Nice state should be used at least 2 non-steroidal as said before, maximal tolerated dose. في كلام كمان ما مهم نقول المهم بس. surgical هي joint replacement, osteotomy. should do osteotomy and replacement of affected joint. The question, what the cause of shortness of breath, as you said, anemia, aortic regurgitation, it's ankylosing spondylitis, restriction of the bone, occur also shortness of breath, apical pulmonary fibrosis. Maybe tuberculosis because the patient used, as said before, adalimumab, Intercept, golimumab. This do reactivation of primary infection or latent TB. Anti-TNF عموما. What is the renal complication للنون-steroidal؟ هي الأميلودوزيس والIgA nephropathy والنون-steroidal use itself. What is the diagnostic criteria? Modified New York criteria. بس خلاص. Well done.
Thank
Perfect, Dr. Samah. Really, yeah, nice case. No, you did well in the explanation. I guess no more comments after you explain. I will just
thank you. بس كلامك
really
انت له طعم.
okay. I will do summary for the examination only because this is the most important thing to do. How to do examination of ankylosing within 4 minutes because Dr. Sarah missed a lot of diagnostic examination, which is your case here. You got the diagnosis. It's ankylosing spondylitis. So what you will examine?
But there is a lot of question I need to ask. So that's, I know some of them I should continue to ask about which type of painkiller, all of this, but I think time was running. And
No. Okay, forget the history now. Okay, the history sometimes, yes, they will judge you on in one skill in the history, which is clinical communication. But there is two skills in the examination: identify the finding and physical examination. For this patient, you have to get full mark. Ankylosing spondylitis as examination is very easy. Okay, so let's start it from the hand. The hand, you have to examine for of course, the deformity. I guess no deformity, no stiffness, because this is seronegative one. Okay, so what else in the hand you can examine? But you can do acting as examining the swelling in the joint in the hand if you have time. But if no time, you can jump direct to the pulse. What you guess the pulse here will be if there is association?
Collapsing due to aortic aneurysm.
Yes, exactly. So yeah, it might be bradycardia or collapsing pulse. This is as character of the pulse or the pulse in the radial. So in the radial pulse, you might have bradycardia, or in the collapsing in the character of the pulse, you might have a collapsing pulse. This is for the hand. You can do proximal myopathy signs just once. It's not significant here because I guess no proximal myopathy in ankylosing. Anyway, you will go to the eye. In the eye, you can check for the redness, scleritis, or conjunctivitis, which is episodic in this patient. So it might be absent during examination. Then the hairline in the face and the back. This is for psoriasis, to rule out any psoriatic skin rash. The same in the elbow. If you suspect, you have to do acting only examining for the rash in the elbow or the scalp area, the hairline. This is and behind the ears. This is for the psoriasis. Then the mouth, any mouth sores, if you suspect something autoimmune, but also it's not the case here. So I am doing the examination for both seropositive and seronegative. Excuse me. Okay. Then in the neck, you can do the raised GVP for heart failure. Then you will do examination of the heart, aortic regurgitation. So you ask the patient to sit forward and take breath in and out and hold and auscultate for aortic regurgitation. The murmur, it will be there if there is. Apart from this, you can do the parasternal heave and loud B24 pulmonary hypertension signs as complication of pulmonary for the fibrosis, but it's not also that diagnostic one. The back for apical fibrosis, so auscultate or expansion, start by expansion first. And before doing any back examination, you have to ask the patient to expose his back. Please expose your back. Okay, we will start by examining the back for the chest expansion. Then the auscultation, you might have crackles. Does it clear with cuff or no? It will be not clear. It will be persistent after cuffing. If you finish the chest examination now, you will do the ankylosing steps. You expose his back already, so you can examine for scoliosis or kyphosis or kyphoscoliosis. This is by inspection. Then you ask him to stand up. Please stand up and do what as I do. I mean lateral movement or forward backward movement. This is for the back I mean the vertebra. Again, you can do the same test in the neck, move forward, backward, and both sides. Okay, this is for the neck limitation or the movement limitation at the neck. Then you will ask him to stand and you tell him, I will go behind you using some tape to make some marks. This is for what, Dr. Sarah? Modified sugar, right? So you will get a mark in the bump at the back or the level of anterior superior iliac spine at the back, then 10 centimeter above and 5 centimeter below then make mark here and mark down, and ask him to bend forward, and it will be limited less than 21 centimeter. Suppose it will be more if there is normal movement, but with limitation, it will be less than 21 centimeter. This is for the modified chopper. So you did a lot of diagnostic tests for ankylosing, which are chopper, and this is must be done. I mean, this is the diagnostic test for clinical examination, plus the association. We know all of us the 7 A's. I guess I mentioned the 3 of them: aortic rigor and fibrosis, apical fibrosis, and what else in the face? Yes, anterior uveitis. Now we'll go to the abdomen, amyloidosis for, you will do palpitation of the kidney for amyloidosis. This is number 4. Then you will go to the knees or ankle, sorry, for tendon Achilles or tendonitis, Achilles tendonitis. This is the 6A. And you can also do examination of the neck of the knees for any crepitus, but it will be negative, suppose, because it's axial arthropathy or arthritis.
And
Okay. I guess this is the examination. You might have also ankle edema for heart failure, but the main thing you have to examine the Achilles tendonitis. Okay.
and AV block.
Yeah, every block in the aortic. Yes, this is the 7/8. This is with the heart examination, bradycardia, AV block and aortic regurg. Yes, you're right.
And also there is occiput to wall test.
Yes, yes, you're right. Occiput wall test, you have to make it while he's standing. In the same time, while he's standing, it will be less than 5 centimeter, and supposed to be. Sorry, it will be more than 5 centimeter, and supposed to be. You can touch the wall by your occiput. This is the normal, but for his condition, he will not touch it. This is regarding the limitation and closing as examination. Let's go to the history taking. You ask him to stop driving, which is very good advice because he has some limitation. However, you can tell him, because this is his job, if we will do some test and if you are okay, your neck movement are okay, the eyes are okay, you can go back to your job, or we can refer you to some teams. They can help you in this regards. The other history, yes, you have to do roll out or exclude the other seronegative, which are psoriatic. You did already, either in the examination or in the history taking. The other one, reactive arthritis, as Dr. Samah said, you have to examine or to take history of casual relationships if he has any of them, or any discharge coming from the private area, or any loose motion recently for enteropathy arthritis. I guess these are the 3 differential: seronegative arthritis, so psoriatic arthritis, reactive arthritis, enteropathy arthritis, and our case here, ankylosing spondylitis. Okay, but really the case was good and high yield in the exam. Dr. Samah already highlighted the points in the clinical point, I mean, and the investigation and the management plan. But don't forget the hydrotherapy, because you will not mention hydrotherapy in PACES except in this topic. Hydrotherapy here is something unique in the PACES, all PACES. So you have to mention hydrotherapy plus the physiotherapy and social worker and so on. The driving issue, you can refer him to DIVLA or according to the assessment. I guess you covered the other points, so I don't have more comment, but the examination, we should do it in systemic way, and I want to take less time in the history. You started examination in, I think, at 11 minutes.
Yes.
So yes, with the time, you should be faster than this, and try to skip the unnecessary questions.
Yes.
Okay.
And I had comment in the exams that I was not systemic in my examination. So how
Yeah,
is
yeah,
it
you have to start from the hand and vital signs.
complain
Sorry.
or start from the examining the complaint back pain? So I will examine the back pain first.
Okay, if you start by the back pain, you'll miss a lot of things in the hand and so on. But if you do examination from the hand, you'll not miss anything. Plus, you can go to the back and you can focus on the back after finish the vital signs, because also a very important finding in the vital signs as well as the hand and peripheral examination. If you miss it, also
In general, because this comment was in my exams that I didn't do systemic examination. So in general, I'll start with the hand, face, chest, abdomen.
yes, exactly. Then back, and be more focused on the back.
Okay.
What we did, yes, we did start by the hands and face, but it will be just few and quick examination. But you will focus more and more in the back. So what I said, you have to expose his back. You can inspect first for any deformity or any change in the shape. Then you can also ask him any pain here. And before starting any examination, please let me know if you have any pain, and find the area of his pain. Mostly it will be sacroiliitis. This is the most characteristic finding in ankylosing. Okay, so you can focus on the examination of the back, but don't miss the other A's. We mentioned very important A's, and if you started by the back, you might take more time in the back, but you will miss the other peripheral signs, which also can give you negative feedback. So my advice always to be systemic, start by the hand. This is also the bestest steps. If you can see past this, they are always starting with the hand, going to the face, then downward in the body. Even the complaint is different. But you will focus on and take time for examination of the affected organ or the complaint. In this patient, you will take long for the back and the Schubert, modified Schubert and the occiput wall test. This is the diagnostic test in this patient. Okay.
Okay, thank you.
Most welcome. Any question from any comments? Well done, Dr. Samah, and good preparation of the case. Yeah, you will learn more than us while you are preparing the case. You will learn from the reading. Now you presented it and you present the case. You prepare a differential for the case, so you also learning from the preparation. That's why I'm asking to prepare the case well. It's for you. You might have this case in the exam, and you prepared it well, and you know what are the diagnostic tests for the patient and the investigation, as well as the management plan and investigation. Okay. Let's go to the second scenario if anyone has comments. Apical from front. I don't think you have to do examination of the apical from front. The best examination of the chest from the back. So don't waste the time to examine the chest from the back and front. Do it once if you don't have time. But in the chest examination, as short scenario, as short case, do it from front and back. But in such scenarios, the back is fair enough. Plus, don't forget the cardiac examination. So don't do both in both direction. So I mean, chest from the back, the heart from the front. Don't forget you have another test to do. In such patient, you will do another. And also, if you have time and you don't know what to examine, you can do examination of the chest from the front. If you have specific finding in the chest, like a rheumatoid arthritis, you suspect there is a lot of finding in the chest, you can do it. But I guess also in the rheumatoid arthritis, you have very frequent finding in the hand, also the tightness, the mouth, the malar flash, or the rash in the face. So I don't think you have time to do all these things. Thank you, Dr. Ahmed. The nail, yes, important. Yes, perfect, Dr. Samah. The nail is important here in the hand, just to also to rule out the finding of psoriasis. Yes, perfect explanation by Dr. Samah, really. Let's go to next scenario. 28 years, Mr. Donald Patrick, complaining of vomiting. 2 minutes دكتور سماح then we'll start.
اوكي الشبكة بس كده ثاني. اوكي.
Dr. Noor also wrote for apical finding from front, from lower lobes, from behind. I don't think you can get a lot of finding from the front by auscultating the chest. Anyway, you can do it if you have time. But for me, I'm starting examining the chest from the back. But if you have time, you can do it from the front.
دكتور صلاح بيقول في واحد من الحاجات الشركة حضرتها دي بيقول from the back even انت كاتش الدياجنوزس من الباب انه ده كايلوزنج او psoriatic او anything complicated by apical
Okay.
fibrosis will start examination from the back and
Yeah,
not go
this
to
is,
images.
yeah.
Yes, you are right.
Typical for the only exception better from front. Okay, you can all other better from the back. Okay. So you mean after finishing the back, you will do examination from the apical, both sides? You mean one area only, not all the chest examination? It's okay, but after the finishing the back examination, it's okay, yes. Thank you, Dr. Ahmed and Dr. Noor. Don't forget also to offer the urine dipstick for amyloidosis. And whenever you want to start non-steroidal, you have to offer renal function test before starting it. And in persistent cases, you can offer monoclonal, as Dr. Samah mentioned, adalimumab and etanercept. When you're ready, Dr. Samah, let me know.
والله أنا شايفة will start because vomiting ده ما مر علي قبل كده. will start إن شاء الله.
Okay.
Okay.
Yeah, here you go. Yes, you can start, Dr. Samah.
Yes, I will start now. You will remind. معلش دكتور باسم البيشن age و name because go
Yes.
outside and
Patient, he is Mr. Donald Patrick, 28 years.
okay, Mr. Patrick, 28 years old. Okay. Hello.
Hello?
My name is Dr. Hassan. I'm a candidate for exam today. I'm talking to Mr. Donald,
Yes,
28 years old.
yes, doctor. I am.
Okay. Nice to meet you, Mr. Donald.
Thank you, doctor. Nice to meet you.
Okay, we are here to discuss some issue related to your health conditions. Okay with you?
Yes, please.
And also we may examine you and may take some notes. But be sure it will be confidential. And all my attention will be with you. So, okay.
Okay.
During our conversation, if you need to ask me any question, don't hesitate to stop me.
Okay.
Can you tell me, Ms. Donald, what brings you to clinic today?
Yes, doctor. I'm having vomiting, and this is bothering me too much.
Okay. When this throwing up occur for you?
I have it for 6 months now, coming and going, coming and going.
I'm sorry to hear that. How do you feel now?
I feel frustrating because I don't know what's happening with me.
Okay. It is the first time?
No, I have it before. Until now, no one told me what's going on with me.
Okay. You seek medical advice?
Yes, I came to the hospital many times and they did for me tests and they said nothing and I'm coming.
No one diagnose you
Yes.
or give you.
Oh,
Okay. Please can tell me, is this showing up associated with uh, with feeling sick
yes,
and
I'm feeling sick and I'm have vomiting, and this vomiting is I'm vomiting maybe 4 or 6 times per day.
okay, I'm really sorry to hear that. This vomiting associated with food particles or bloody?
No blood, but sometimes if I eat something and I vomit food, if I'm not eating, I'm vomiting some clear fluid, which is yellowish fluid. So that is not related to food.
This occurs in 6 months, you said.
Six
Not
months.
not take any medication to stop this.
Yes, I tried to take some medications. They gave it to me, but it's not helping too much. The vomiting return back
Okay. This occur for 6 months continuous or on and off?
on and off.
Okay. Anything to make it better?
Yes, sometimes when I'm having a hot shower, it's decreased my symptoms. This is the thing that I notice.
What? Hot shower decrease the
Hot shower.
symptoms?
When I'm taking hot bath, it helped me.
Yeah. Okay. This occur at night or in a
No,
specific time in the day?
all over the day I have this vomiting.
All over the day?
Yes.
Okay. Associated with tummy pain or
Yes, sometimes
um
I'm having pain in my tummy.
what?
Sometimes I'm having pain in my tummy also.
Okay. Any tummy distension?
No distension, only pain.
Only pain?
Yes.
Any yellow in your eyes? Yellow discoloration in your eyes or skin?
No.
Nothing? Any
No.
difficulty in swallowing?
No.
Any loose motion?
No.
Any hard motion?
No.
Any pain, bulky, stool, offensive?
No.
Okay. Any change in your back passage?
In what?
Any difficulty in control of your back passage?
No.
Okay. Any high body temperature?
No.
Any lump or bumps anywhere in your body?
No, I didn't notice that.
Any weight change? Increase or decrease?
I think my weight is running. I'm losing 2 kilo, gaining 2 kilo. Not stable, but because I'm not eating sometimes, and food is not staying in my stomach, in my tummy.
Okay. Okay, I'm really sorry to hear that. This loss motion, weight loss intentional or not?
No, it's not. I think because of the vomiting. When I'm eating,
Oh,
when I'm having this vomit, I gain this 2 kilo.
okay. Uh, 2 kilo in how months?
No, when
In
the
how
vomit
many months?
start to eat normally and vomiting have some relief from this vomiting, as I told you that the vomiting is coming and going. When I have some rest and the vomiting is not present, I'm gaining this 1 or 2 kilo again.
Okay. Any night sweating?
No,
Any lumps or bumps in your body?
I didn't. I told you no.
Okay. Anyone tell you became paler than before?
No.
Any change in your appetite?
No.
Any weather preference?
No.
Okay. Um. Okay. Anyone of your family have same problem?
No.
Any skin rash?
No skin rash.
Any joint pain?
No joint pain.
Um. Okay. Any change in your water work?
No.
Any frosty water work?
No.
Okay. Um. any this pain, this abdominal pain radiate to any area? Go
No,
to back or no?
no,
Okay. Can tell me, Mr. Donald,
hmm?
you have any past medical history will be aware of?
No, I don't have any medical condition.
Okay. Um, any past medical history of surgical operation?
No,
Any past medical history of blood transfusion?
no,
Any history of uh, traveling, recent traveling?
no. I'm in UK for 2 years.
Okay. Any history of unprotected sex or needle sharing?
No, I'm protected sex. I'm not sharing needle.
No sharing needle? No any history of tattooing or
No,
nothing? Any can show me drug list?
I'm not taking any drugs. The doctor gave me only medication called on the citron, I think, for the vomiting. And I'm not taking it regular.
Not taking regularly? Uh, any allergy to any medication?
No,
Okay. Um, any one of your family have similar condition?
any family history of similar condition? No,
Yeah, yes. Any family history will be aware of?
no.
Okay. Um, uh, can tell me,
What?
okay. Um, um,
Continue.
Social,
my
occupational. You
mind.
have still occupational
Okay,
and social.
Continue.
occupational. Okay. Uh, please, Miss Donald, can tell me what is your job?
I'm working as in a supermarket.
Yeah,
I'm on cashier.
yeah. Um, okay. Uh, how this is affect your job?
Yes, sometimes at work when I have this vomiting, I'm going too much to the loo, and this is bothering me at work.
Okay. You refer you to social doctor and occupational health doctor to help you with this issue. Are you a smoker or are you a smoker?
Yes, I'm smoking.
How many and for how long?
I'm smoking 10 cigarettes for the last 10 years.
What?
10 cigarettes for the last 10 years.
Okay. Should you stop this smoking because harm for your health? And if you don't mind, I will refer you to social health doctor, to smoking cessation doctor to help to stop smoking. Can tell me, do you drink alcohol? Much alcohol?
Socially.
Okay, should stop alcohol because may affect also your health.
Okay, I'm not drinking too much wine.
Any extramarital relationship?
No,
Hmm?
no, no, no.
Okay. Um. Do you have long-standing disease, diabetic, high
No,
blood sugar, high blood pressure?
no,
No.
no.
يا حياتي أنا معك. Also no history of traveling, you said.
No,
Okay. Um. I want to examine you, if you don't mind.
Yes, please. What do you examine?
Okay. General, pulse, blood pressure, sitting and standing,
Normal.
normal.
Yes.
Pulse rate, also normal.
Yes. Vitals normal.
Okay. Any pillar or clubbing in hand?
No.
Any palmar edema?
No.
Any skin pigmentation
No.
in hand? Okay. Any pillar in eyes or jaundice?
No.
Any neck stiffness? Any neck, any any lymph node in the neck?
No.
Okay. Can examine your abdomen,
Yes, please.
superficial palpation,
You will find it rigid. Abdomen is rigid.
any
Only.
area of
Only
any
rigidity.
area of your body,
No.
rigidity.
Only rigidity.
Okay. Uh, which area in the abdomen most
The whole.
most
The whole the patient
all
is.
abdomen?
Yes. The patient is stretching his abdomen.
Okay. Okay. Um, deep palpation, any organ
You
usually?
could. You couldn't do it because the patient is make. I think rigidity of the whole abdomen, so you couldn't do deep palpation. You couldn't appreciate.
Okay.
2 minutes left.
Okay. Auscultation, anything in the abdomen? Auscultation.
No. No.
Lower limb swelling.
No.
Okay. آه ما في حاجة كتيرة ما في في شنو تاني اوكي can tell me Miss Donald anything not remember it in the history
No.
you have
No. I
abdominal
don't. I want
tummy
to know
pain and vomiting or
no,
throwing up
only these things.
not
Mm.
okay there is any history of graphels or stone before in your abdomen or in
No.
your renal
No.
oh, no also uh, ما في do you have any concern صراحة ما عرفت do
I
you have
have.
any concern
I have two concerns. The first concern, why I'm having this vomiting. The second thing, when I'm coming in the room, the nurse was looking at me, smiling that you are, as she's mocking of me that I'm coming to the hospital and I don't have anything. Because I'm coming many times in the hospital and then they said you don't have anything. I didn't like the look of the nurse while she's looking at me saying, you are coming again?
um uh I don't know I think but he said no fever صح any high body temperature before
No.
no also no joint pain or no joint rush
No.
maybe yes uh okay خلاص انتهى الزمن ما عارف والله ما عرفت الدياجنوز الصراحة uh,
Okay, time is up. Let's go to
I
the
think
examiner
functional.
question.
I think functional. You have functional disorder. I think.
Yes. So present your case.
Miss Donald, 25, 28 years old, male. Complain of recurrent throwing up أو recurrent vomiting. بما إني هتكلم على examiner. Recurrent vomiting and sometimes since 6 months and sometimes associated with tummy pain. No other thing significant in history. Um, And also in examination, there is abdominal pain and rigidity. ما في كلام. دي
Thank you.
البوزيتيف غايته جدا.
So
What is
what is your diagnosis or differential diagnosis?
from history and examination, maybe gastroenteritis. This
Mm.
in the top of my differential. Uh, uh, and oh, again, is this no loose motion and no high body temperature and maybe infection. Other infection besides the gastroenteritis, maybe inflammatory like pancreatitis, appendicitis, maybe familial diphtheria fever, but against this, no fever and no joint pain also, and no history of recurrent serositis in other area of the body. Maybe acute intermittent porphyria, but against this, no. أنا ما سألت منها. No psychiatric issue and no CNS manifestation also. And maybe intestinal obstruction, but again, is this no hard motion and um, no constipation. Maybe other strangulated hernia.
And what
Other cause of causing vomiting, but
so
acute abdomen also pancreatitis or maybe appendicitis also.
okay, so what you'll do for
Upper abdominal pain. Investigation.
yes, what you'll do for this patient?
Apart from basic investigation, CBC, RFT, LFT. CBC will look for white pieces for any sign of infection, and RFT, and also for renal function test, and for liver function test important, and for ESR reactive protein, and for viral screening for hepatitis, um, hepatitis B, hepatitis A, hepatitis C, and also do investigation abdominal ultrasound to exclude acute abdomen. Do for him serum amylase and lipase to exclude pancreatitis. To do for him, to do for him, maybe do for him gastro endoscopy to look maybe some gastritis, gastric ulcers, to
Okay.
exclude the gastritis.
If this patient all the tests are normal, what do you think the patient might have the cause of vomiting?
Functional disorder, somatization.
Yes. Okay.
Maybe bulimia nervosa.
Good. Okay. And what you will do for this patient? What's the treatment for this patient that you will offer him now till you get the diagnosis?
Again, manage.
The treatment. What's the management plan?
The treatment, look for vital sign. If normal, we'll give him non-pharmacological counseling, education about this condition. Need to refer him for mood doctor and gut doctor. يعني نعمل full exclusion, gut doctor, mood doctor, and specialized staff nurse. And also social doctor, and because he complained from job or inside of job, and occupational doctor, and also refer, and also pharmacological, give him anti-emetic medication. If patient unstable and vital not good, we'll give him fluid, IV fluid. Maybe need admission and electrolyte correction if develop hypokalemia from this vomiting, recurrent vomiting.
Good. Fine.
And also,
Fine. Oh, okay.
Yeah, time is up.
Okay.
Yeah, we can hear your comment, Dr. Sarah, please.
Okay. First of all, Dr. Sameh, this is a real case that I have in my exam. Okay. So it's a difficult case. I will tell you the case, but let's start from the beginning for you. You introduce yourself good, but don't say to the patient everything is confidential. You don't need to say that. because this can deduct from you some work, because some conditions that are not confidential. So don't say that everything is confidential, because he might have HIV and he has at risk of other people. So don't put this word, and it won't help you in anything in the exam and won't give you mark. Remove this from your scenario. I know that all of us, we are putting an introduction to the patient, but don't say, I want to tell you that everything is confidential. No. Okay. This patient is coming with vomiting. Okay, it is a young patient coming with vomiting. In between, now is telling you that I'm frustrating. You didn't you didn't say I'm really sorry about that. You say it in other concerns, but one of them, when I'm saying any patient saying anything, try to address his concern immediately. I'm really sorry about that. It sounds frustrating. It sounds difficult for you. So you skip this in one of them. This patient, he has vomiting. You ask about everything. This case is difficult, but you didn't ask about any. You ask about sharing needle, but you didn't ask, are you using any recreational drugs or no? And this is the key of the question. Okay, this patient is smoking cannabis. Okay, and the diagnosis here is hyperemesis, cannabis hyperemesis syndrome. Okay, or syndrome. So when you ask him, he will say, I'm smoking cannabis. And then when you start to examining him, it's difficult case. For me, I didn't get the diagnosis, but I passed this station because I say, I asked him about this cannabis, and when the examiner was asking me, what do you think it might be the cause regarding his social history? So I told him because he's smoking, and also he smoked cannabis, but I'm not quite sure it's the cause or not. I didn't know the diagnosis itself, but I say it is one of this cause. Okay. So when you start to examine this patient, when you start to examine him, this patient is coming with vomiting. So you should examine the skin turgor, the mucous membrane for dehydration. So this is some of the important things in the examination that you missed. Okay. Tell him to pinch your skin. Don't pinch the skin for him. You will tell him, can you pinch your skin to check the skin turgor? Can you open your mouth to check the mucous membrane? Do the capillary refill time, because this patient has vomiting, he will be dehydrated. Okay. And I think this is what you skip in the examination. Okay. And then when the examiner and the patient told me the things, told me my concern that why the nurse is looking at me. So I told him this is really unacceptable. So I will have a talk with her and come back to you, because the nurse is looking at him because he's coming to the hospital on a recurrent basis, and then she thinks that he's malingering, that he's ill. So this is one of his concern. When I know that he was paralyzed because he didn't get the diagnosis, so you didn't address his concern. But you might find in long case examinations that the patient has concern that you need to address it. And when I told him only these things. I told him this is not tolerable, so I will go to have a talk with her and check what's happening and then come back to you. And they gave me the full mark in this. So even with small words, you address his concern regarding smoking. And when I told you I'm social drinking, you don't need to tell me, because I'm not drinking too much. You don't need to tell me to stop alcohol, because I'm social drinking. Okay. In the investigation, you did the differential well. Okay. So when I ask you what is the cause, you said the functioning. It could be functioning disorder. Okay, which is functional inflammatory bowel syndrome. It could be. And the differential diagnosis, as you said, it could be gastritis, chronic pancreatitis, infective colitis, Addison, hypoglycemia. Okay, so this is a differential. You tell the differential well. And in the investigation, you said I do abdominal ultrasound for acute abdomen. I think to check for the acute abdomen obstruction, the X-ray, not the abdominal ultrasound. You won't get anything from the abdominal ultrasound. From the X-ray, you find megacolon or paralytic ileus. So this is the thing. And this is my comment. So the differential also could be cyclical vomiting, okay, and functioning. For this patient, what you will do for him, as you said, all this investigation. But for the patient, you said I need to admit him, to give him fluids, PPI, and to give him antiemetic. And you should, if you know the diagnosis, you should advise him that the cause is the weed or the marijuana. He was smoking marijuana. The marijuana that you are smoking, you should stop it. But for me, I didn't get that this is the cause. And this is when I didn't know from the exam. And when I went home, I asked one of my colleagues that working as a GP training. She told me this is cannabis-induced hyperemesis, and we are seeing this case a lot of in the GP practice. So first time I know this case. Okay, and I got it. The patient was only having vomiting and recurrent vomiting. And also the vomiting, when you will ask him, some patient will tell you, when I get a hot bath, it relieves the nausea and vomiting. This is also one of the diagnoses of the cannabis-induced hyperemesis. Okay, the shower and hot bath. So what is the mechanism of cannabis? Cannabis is one of the medication, because when the examiner told me why the cannabis is causing, you don't think what if from the social history you can think about cannabis, and he wrote it in the comments that and he gave me the lead, but I didn't know the diagnosis. He told me what things regarding the social history, but they give me good mark because I said it's one of differential. Okay, but I went to read about the cannabis. I found that the cannabis is preventing the vomiting. So the cannabis has two main action. The first action is to go to the brain and decrease the vomiting and nausea, and the other action is work on the stomach itself and induce vomiting. Okay, so with when the patient is using cannabis many times, so they will lose the effect of it to control the brain function of it in vomiting and nausea. And they think the patient that when he took the cannabis, it prevents, but it aggravates the condition. And this condition is treated only by stopping smoking. Okay, so this is my comment for this case. And I know it's difficult. You don't need to be frustrated. It's a difficult station, but I got it. Okay.
Yeah, thank you, Dr. Sarah. This is the lesson, Dr. Sarah. Although it was difficult, although you didn't reach the diagnosis as a top differential, but you got full mark. Why? Because sometimes they are judging you on the approach, how you approach the case from the history, your questions, every single question in the scenario will give you a mark. So don't be frustrated if you don't reach the diagnosis. Still, I can do, and the examiner sometimes they can help you while asking you at the examiner question.
Hmm.
And by one answer, you might get the full mark, like in this scenario, or like in your scenario. Why he give you the full mark? Because he knows that you understand the case, you understood the case, and you reach the diagnosis by good approach. You ask everything and you find everything is negative, apart from the cocaine or cannabis. So you correlate it with the cannabis and he give you the mark. This is my opinion. And this lesson also for Dr. Samah. Don't be frustrated at the end saying, oh my God, I didn't touch. What I will do now? Nothing. Really.
Because if easy case will be frustrating, will be يعني
Yeah.
rare reach to spot diagnosis. Due to this, uh,
As I wrote for you.
we'll try to do best. You get my point?
Exactly.
But after file this became no
No, no.
problem. Now
We are
we will
learning
add
from the
something.
difficult. Yeah, we are learning from the difficult more than from the easy. Today, I practice a case with Dr. Moses. I don't know if you are following with him. He gave me a case of knee pain. Imagine what was the diagnosis.
What?
It was
Septic?
alkaptonuria. No, not septic. This is what we are practicing. Septic arthritis, psoriatic, pseudogout, alkaptonuria, which is very, 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 very rare. But I guess Dr. Sarah mentioned in the different, or Dr. Samah, sorry, while you are saying about ankylosing, you said alkaptonuria. But no one will
But
guess, or
rare,
no one.
very rare.
Yes, but
Mm.
he said this case was in UK. So I guess in UK they are giving the candidate such kind of difficult case. But what we are learning, once you practice this case once, you will never forget it. Why? Because it's rare, and once you do it once, you will not forget it. So whenever you have patient with vomiting and everything will be negative in your exam, you will remember this case anytime.
Inshallah.
Because Yeah. Why? Because you practice it one day with Dr. Sarah, and we'll just remember the questions and the title of cannabis or hyperemesis or induced hyperemesis or whatever. But still, your differential, you will get a good mark. You will get a good mark also by physical examination. You will get a good mark in the identifying the physical signs. So it's not the diagnosis only. You can get good mark in most of the skills. How? Clinical communication. You will ask everything. You will get the mark. Okay. For the differential, you might be minus in this skill. But if you mention at the end or the third or the fourth differential, he might give you the mark. But forget it, okay? Forget the differential. You have another skill, which is clinical judgment. He will ask you about the case and the management and the investigation. You might get mark also in this. So the concern, the other skill, you can get the full mark easily. Any answer in the concern with the simple word, you can get the full mark. But you have to ask the concerns, the whole concern, and you have to cover all concern and to answer or to address all concern. You will get the mark. The welfare, you will get a mark also because you always keep or save the welfare for the patient. You always ask permission. You ask for painkiller. If you have any pain, let me know. All these things can give you the welfare mark. Okay. So what remains? The physical, we mentioned the physical examination and identify physical sign. So what you will be minus in this scenario if you didn't reach the diagnosis might be in the differential and or in the clinical judgment because you didn't give good information if you don't know the topic. But believe me, you can get the mark unless the examiner is tough or malignant one. If you reach the diagnosis or not,
inshallah.
yes. So don't give up. Don't say no, I didn't reach diagnosis. What I will do? And remember always, you might reach the diagnosis, but he can minus you. Why? Because you didn't do what he wants. So it's the matter of
Yes.
the exam. It's not your wish, or it's of course after Allah wish, but sometime the examiner handling this. He can give you very bad mark while you have the diagnosis. In the opposite
Yes,
side,
it
he,
happened with
yes,
I
it happens.
Okay.
yes, I diagnosed transit global amnesia, and it was the diagnosis, but I failed this station because I didn't ask about transit ischemic attack.
So you see, it was difficult, but she got the full mark, and
And
the easy one, because she didn't ask about something he wanted her to ask about, and he can give very bad mark because of this question or because of this judgment. So they are crazy sometimes. They are giving bad judgment, but what to do? This is the basis, and we have to fight with them.
yes,
We have to pass by fighting that. This is the truth. Okay, so Dr. Samah, um, I'm repeating this advice. You are not beginner anymore, by the way. You are saying I'm beginner. No, you are not. You listen how many sessions with us, so don't consider yourself still
But
a beginner.
every time to add new information and give me more
Yes, we are
confidence.
learning. We are
And
learning.
yes, yes, Alhamdulillah. When present other case, many times reach the diagnosis, but in start nothing. Alhamdulillah, every time with you, get more with advice. Now, get two important advice. If don't know the diagnosis, will answer the concern. I will searching, I will call
Yes, yes.
consultant. Like this.
and also don't.
Another thing,
Hmm?
finish, Dr. Asal. What you say?
I'm saying that because all of us had this in the exam, and me too, I got paralysis in the exam, and one station I stopped at the 6 minute. No, try to ask. Even if you didn't get the diagnosis, ask and try to overcome it. And because when you become confused and started to be paralyzed, you won't do anything. If you didn't get diagnosis, or continue to ask, or maybe try to start to examine and think about the complaint. Complaint is vomiting, so I need to check about the complication of vomiting, which is dehydration. So I need to check the skin. So if you give me the differential, very good. And I know I didn't say acute intermittent porphyria. I didn't say the familial Mediterranean fever, which are important in this young age men with abdominal pain and vomiting. So you got more differentials than me, and even the examiner didn't write this differential as that you said. So you have more knowledge. So you should the only thing in the station, if you do the examination by checking for dehydration and address his concern regarding the nurse, you will pass the station. If you didn't, and you ask about the smoking, and because you said, are you sharing needle? No, ask, are you
Okay.
taking any recreational drugs? He will say yes or no. Okay, and do you share needle? Which drug you are taking? Because he might say cocaine, and the cocaine is the cause of stroke. He might say cannabis as this case. He might say any medic. So you need to know what recreational drug he's using, and don't say sorry. You can say, are you taking any recreational drugs? In the exam they are not um I think because this is an international, they won't give you mark on that you're saying sorry to ask you this question about the recreational drugs, because you can ask it normally. So ask him, are you taking which type of recreational drugs? Do you share needle? Do you share straw? Sometimes in cocaine they are sharing straw, so you can advise him, sharing straw can transmit virus C, so I advise you not to do that. So this is the thing. You ask about the recreational drugs, but said you enter that the patient is injecting. No, you didn't any recreational drugs, and then he will say which recreational drugs. And if you said cocaine, so you don't need to ask, are you taking any recreational? He said no. Okay, and then if he's taking any injectable, are you sharing needles or sharing straw? So this is you make it. You missed only the recreational drugs, and you mean if you have it that he's smoking weed, you might say it because he's smoking weed. Because I said in the exam because he's smoking cigarette and weed, but I don't know about the diagnosis itself. So be confident, and if you in the exam try with the practice, I think we are till now. And for me till now we are practicing. With the practice, we will become more confident, and we will continue the station till the end. You won't be paralyzed in between. So
Inshallah.
Yes, I
Good
agree.
advice. I will do.
yes,
Yeah,
Inshallah.
I agree with Dr. Samah, with Dr. Sarah. You have a lot of things to ask about. If you if you already cover the system, if you cover the social, if you finish the social, go to the occupational. If you cover all, go to the examination. I guess most of us or all of us, they will have short time in the exam, so no time to pause at all. Don't stop asking or examining till the 13 minute, the 2 minute left for the concern. So you have 30 minutes, no time in the middle or at the end or the start to be quiet or to be having a mental block. You have a lot of question. If you go from downward as system view, you will have at least 4 minutes from the head, the chest, the abdomen, the waterwork, the joint, the skin rash. You will finish, then you will go to the social. If you finish, you go to the occupational. If you finish, go to the examination. By this way, never ever you will stop. If you feel you are blocked, go to the next, which is, for example, social. You finish or you stopped, you go to the next, which is the occupational, smoking, alcohol, job, and driving. Okay, then the examination. If you finish examination, still you have time either to tell here, let's summarize what we have discussed and add any point if you want to add, or you can ask something you remember during examination, but never ever stop being quiet. Okay, 2 minutes left. Start the concern immediately. In concern immediately, 8 mark for each station in the concern. 8 mark. Imagine 8 mark. So don't miss the concern, whatever you did in the history or examination. Okay, let's
That's
comment.
good.
Yeah, Dr. Ahmed or someone wrote about social doctor. It's not social doctor, it's social worker or social team. Or so the occupational, also occupational team.
I think she said smoking doctor. Smoking, no,
Yeah, smoking cessation. So you have to correct these
smoking.
things.
Yes.
With practice, you will do it. Physiotherapist, yes, so psychologist, and while talking to the examiner, talk him in medical terms. Don't say mood doctor to the examiner. Why?
Yes.
He can't understand the psychotherapy or the
Talk,
psychologist.
talk scientific.
Yes, be scientific
Mm.
more. Okay. Uh, let's go to the other comment. Important to ask about illicit, yes, and mood in every single scenario. Yes, sometimes it will be your clue in the scenario. So
Mm.
the illicit or recreational drugs, I will give you example in paces. You might have MI due to cocaine. You might have headache due to cocaine. You might have hypertension due to cocaine. You might have chest pain as MI again because of cocaine or recreational drug. You might have HIV and infectious disease due to sharing needles, and again, it's recreational drugs. Okay, you might have also respiratory dysfunction or depression because of morphine or opioid injection or opioid as recreational drugs. Okay, so in PACES, you might have a lot of things due to the recreational drugs, but the most important, the indirect effects, like infection from sharing needles, like HIV or hepatitis B or C. Okay, this is important to know about recreational. But please, if you want to ask about HIV in such age, you have to ask about recreational drugs. Plus, of course,
Yeah.
the casual relationships. But tattooing, piercing, if you have negative recreational drugs and still you suspect risky habit, you can ask for the tattooing or piercing. Blood transfusion, it will be in the old age patient, 60s and 70s before blood screening, if you suspect hepatitis, for example. But as blood transfusion nowadays, the blood always clean. So don't expect you have patient with hepatitis after blood transfusion. If you suspect hepatitis in a young patient nowadays, you can think about anything apart from blood transfusion. But blood transfusion will be a clue for hemochromatosis patient or for thalassemia patient, or if you suspect hemolytic anemia patient. The question for her blood transfusion will be important. Okay? Thalassemia, you will get,
Even when
yeah,
even if the patient young and examine blood, there is minimal risk of maybe not examine well, maybe carry risk of transmitted infection. There is
as,
minimal risk, not like before, but there is risk of.
but they will not bring as the case of blood transfusion related infection. But if
Mm,
you have suspicion, but it's important to ask this question in, as I said, thalassemia, secondary hemochromatosis, or any hemolytic anemia disease. Why? Because the question will give you the clue of recurrent transfusion for a need of transfusion, not for infection. No,
mm,
for a need of transfusion in
mm,
hemolytic anemia patient or secondary hemochromatosis because of repeated blood transfusion in the secondary hemochromatosis
mm.
patient. Okay, so this is
Okay.
the clue of blood transfusion. But the recreational, I said, how about the recreational and what's the importance? The blood transfusion I mentioned, tattooing and piercing for HIV, of course. Tattooing and piercing for HIV. That's it. Or infective endocarditis. Okay, and infective
Or
endocarditis
hepatitis
or
also,
hepatitis, yes, or hepatitis.
because
Yes,
he has vomiting and tummy pain.
yeah,
Maybe hepatitis.
yeah, I'm talking in
Mm.
general. But hepatitis will
Yes.
patient definitely in hepatitis in any hepatitis patient definitely or most probably patient will have jaundice, which is not
Yeah.
in this patient. Okay, but you
Mm.
did great about thinking. And when you start any case scenario, ask yourself what I am looking for. For example, in this patient, you suspect gastritis, so put gastritis in the differential. What or how or what the patient or what which kind of patient will vomit? Either gastroenteritis, duodenal ulcer, for example, or something central as uremia, right? Or increase intracranial pressure, right? Will be like hemorrhage, subarachnoid hemorrhage. projectile vomiting, I mean. If you find these things, okay. If not, go one by one until you reach the diagnosis. But the good thing here, you did a system review, which is the relevant system here. You did it very well. You covered the whole relevant system. I mean the GI, difficult swallowing, vomiting of blood, what you are vomiting, the food particle, any difficult swallowing, any mouth sores, any loose motion, any hard motion, any distension or abdominal discomfort, any change of your eyes color being yellowish, any pallor, or anyone told you you are paler than before. All these questions related to the GI, and it will give you a clue about the diagnosis. However, here it was negative, so it's something induced or something in this only stomach, local, I mean, or topical, or something related to only stomach, not in all system, or not in the whole GI or gastroint in the bowel itself. Okay. I guess you
Yes.
did well, Dr. Samah, as professional beginner. Now I will say you are professional beginner. you
Okay.
you promoted.
This beginner word irritate you.
Yes,
Okay.
always you are saying I'm
Uh,
beginner. So you are professional beginner. Okay,
yes,
leave.
because less than 1 month is beginner. If 2 months beginner, if 3 months beginner. I will ask a question. If ask about smoking, because marijuana is the smoke stuff, smoke,
Mm-hmm.
not
Yeah.
drugs take.
Mm-hmm.
Can I ask how any history of smoking? He said yes. For how much and how long? Can I ask what's
No,
the type of smoking?
no,
Can I
no,
ask
no, no,
about
no, no,
the
no.
type?
Marijuana is still under the term of recreational drugs.
Recreational?
Yeah, but
Okay.
the way of injection, or the way of injection, will be by inhalation or by smoking or by injection. Oh, so you can ask any recreational drug. Yes, doctor. So what are the medication, or what are the drugs? I use this marijuana, for example. So the marijuana, how you are using it or how you are taking it. I am taking it by either inhalation as smoking. The morphine will be inhalation. The other will be injection, like cocaine and some opioid injection. Okay, and whenever you have this in the history, you have to do examination of the injection marks, especially in the inguinal areas and in the cubital area, plus lymph node examination, because always this needle are a dirty one, so it will carry the risk of infection. And we will have in the injection site some pus and also some papules associated with some enlarged lymph node. Okay, this is the clue for recreational drugs. You have to ask what is it and how you are using it. And did you share needles? Collectively, these questions will give you the clue of the case. Maybe it will be only this thing in the case, and you will be positive, finding only this thing in the case, and you can diagnose as this patient have a drug-induced hyperemesis. Okay. Any other question? Okay, let's read the comments quickly. Catecholamine, yes, this is me. I joined meeting. You did nice history. Yes, Dr. Hadil give you also some promotion to professional beginner. Cyclical vomiting, cannabinoid hyperemesis syndrome. Yeah, I will share it to the group. Symptom: cyclic vomiting, abdominal pain, relief with heat, dehydration. Yes, I'm repeating this advice. Whenever you take history for the complaint, try to find out is there any alarming signs. So whenever you have diarrhea or vomiting, how do you compensate? This is very important question. Why? Because if he's not compensating the amount he is vomiting, or the amount he is putting in the diarrhea, patient will be having dehydration. And according to the signs of dehydration and the degree of dehydration, either to admit or not. So always ask this question. I'm vomiting 6 times per day, doctor. And how do you compensate that? I am trying to drink water, doctor. If he did so, the patient might be in the euvolemic state. However, if he is not compensating that, the patient will be dehydrated. Definitely, he will be dehydrated. Why? From where he will get the fluid? Unless he is admitted to the hospital, he got some IV fluid and so on. So you have to ask this question in the history and to examine him, the skin turgor, as Dr. Sarah said, and the mucous membrane, and so on. Dry mucous membrane and the dry skin. Okay, and sunken eyes, of course. Blood pressure also sitting and standing, postural hypotension. These signs is very important in two patients, the vomiting and in the diarrhea. And you can add also polyuria. Patient with polyuria and he's not compensating, he will have also the same signs of dehydration. These three patients you have to ask about, are you compensating well? And you can ask about dizziness. Are you feeling dizzy while standing from sitting position? Okay, this is related to the alarming signs and how to compensate and admission or no. The second, the second photo, the same, I think. Thank you, Dr. Basim. Thank you, Dr. Samah and Dr. Sarah. Sunken eyes, yes, of course. Any other question? I hope I read the whole comments. And if anyone has any comment, please share it with us. Any other comment, Dr. Sarah, Dr. Samah?
No, sir.
Okay, thank you, Dr. Sarah. And nice performance, nice cases as usual. You are giving us new cases, which is difficult, yes, somehow, but we have to learn these difficult scenarios. Believe me, you will be in trouble if you face such scenario in the exam and you don't know what to say. Better to say it here and better to face it in the meeting rather than in the exam. So again, I'm thanking you, Dr. Sarah, and also Dr. Samah for the preparation and practicing today. If no more question, we can end the session. Thank you, Dr. Ryan, as well. Okay, no more. You are in the right track, Dr. Samah. Don't worry, you are learning a lot. Okay, see you tomorrow, inshallah. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.